Good. Hi, friends. Uh, Welcome to another episode of Innovations in Genomics. And hi, friends. Welcome to another episode of Innovations in Genomics. And we have got none other than Nikhil, who has been the spearheading the work in genomics, is well known in the country from a well-renowned hospital, Tata Memorial, which has given us the directions of which way we should be heading into the arena of molecular hematology. And not only this, but he has been able to produce the world class students of him, which has been taught so very well, and then populated the rest of the country so as to make the genomics popularized into the hearts and the minds of the hematologist. So it's very, very dear to us, this topic is because we also want to understand that conventionally, as a hematologist, we were doing only flow cytometry, and now the AML MRD has started spreading its wing into the arena of science. And the world has already been doing. We sometimes do not tend to use it because of the cost. So it is 45 minutes of ours. In next 45 minutes, it's an opportunity to learn from two giants who have been able to practice the art and science of NGS MRD, of when to do, how to do, and where to do, in which subset it's absolutely mandatory, because the whole ideology of today's Fortis Institute of Blood Disorder is test more and treat less. Will be able to succeed in this? Is this test really expensive that we should not be doing it? So please get to tune in to next 30-40 minutes to understand these aspects of NGS MRD. So over to Dr. Srinidhi, who is doing a fantastic work in the arena of NGS MRD. And also Dr. Astha is also there, who's been spearheading for years together the NGSM flow MRD. So how to combine the both and best of both worlds so as to serve the patient better. Over to Dr. Srinidhi. And listening to Dr. Nikhil is always fruitful and exciting. So thanks again, Dr. Nikhil, for giving us this opportunity. Thank you. Over to Dr. Srinidhi.
So, good evening, everyone. I won't take too much of your time because Sir also has prior commitments, and I won't take too much time. He needs no introduction. He is the Dr. Nikhil Patkar, who's actually taught me also, and he's professor and clinician scientist at Tata Memorial Hospital, Mumbai, in pathology, and he has received many awards, which are countless, which I don't want to take time and waste his time and what we have to do. So, sir, I'm not going to take too much time, and it's totally over to you. And thank you so much for accepting.
Can you see my correct screen?
Yes.
Yes.
Okay, very good. So thank you, Dr. Rahul and Dr. Srinidhi and all colleagues and Dr. Asta for inviting and me to give a talk. So I'm going to talk of AML MRD, the what and how, and we can have an interactive session if there are any questions or whatever. So AML, as you know, is a disease that originates from clonal expansion of myeloid blasts. Other than AML with 1517, AML has a heterogeneous biology, and this heterogeneous biology results in heterogeneous outcomes. So we know that patients with poor risk cytogenetics do badly as compared to patients with favorable uh, uh, cytogenetics. All right. So, but the classifications of AML have been rapidly changing, and these changes also reflect a change in technology over time. So, initially, AML used to be a cytomorphologist's game where they used to do morphology and cytochemistry. Subsequently, they started doing flow cytometry, and then we had the real classification. Then the WHO series of classifications came, which initially looked at gene mutations, then next generation sequencing, and now next generation sequencing is very much used to define, diagnose these subsets of leukemia. So AML, as you know, is a genetically less complex entity. You can see here that AML genome is less complex as compared to some of the solid cancers. So the number of mutations that you see are much lesser. And even then, when you look at different subsets of AML, they have different mutations. For example, if you see RUNX1, RUNX1 T1, the number of mutations, or AML with 821, the number of mutations are lesser as compared to, let's say, intermediate risk AML, where the number of mutations will be far more in its in the genome. So initially, about 5 or 10 sequencing, everything is not feasible and not required also. And these targeted sequencing panels are based on these pathway of genes, and these then got transformed to gene panels, which are so used by several people in the laboratory. So at least this is a data that we published from our hospital of nearly 400 patients of AML, that at least one mutation can be detected in 90% of our patients, even when small panels were used. So this is data from the last decade, really. But it brings forth a question, and that is what we are going to answer now. So if we use panel based sequencing to detect mutations, can it help in detection of MRD? And this is the question that we sought to answer some time ago. So before we understand or start sequencing patients who are post remission or in morphological remission, you must be aware of this phenomena of clonal hematopoiesis. So clonal hematopoiesis was discovered again in the last decade, where we found that as patients tend to age, they start to accumulate mutations in the genome, and as they grow older, these number of mutations increase. So typically your DNMT3A, TET2, ASXL1 are the most common mutations that are seen in clonal hematopoiesis. The thing is about clonal hematopoiesis is that these mutations occur early in the mutation hierarchy, and these are present at high VAFs. They these mutations persist in CR. That means if you take patients who are in morphological remission, patients of AML, and sequence them, you'll find that these mutations persist and at the VAF, which is high. And they are present even in relapse disease, because they occur in hematopoietic early progenitors, which are not don't go away. So those particular mutations are, even if they are in CR, they are not associated with increased risk of relapse. And when you give patients transplantation, they are eliminated following successful transplant. So this is data that from our lab, and what we did was we looked at patients who had AMLs and tracked DNMT3A mutations in them, and you can see that as these are patients who have NPM1 and DNMT3A co-mutated patients. So if you know, NPM1 mutated AML is often accompanied by DNMT3 and TET2 mutations. So you can see that these NPM1 mutations start to go down at post-induction, post-consolidation time points, but the DNMT3A mutations persist and higher VAF. And this is because of the phenomena of clonal hematopoiesis. And therefore, DTA mutations are unsuitable markers for MRD monitoring. So this is a seminal paper which was published in 2018, which showed that if these DTA mutations are excluded, those patients at post-induction or subsequent time points, if those mutations persist, they are predictors of higher cumulative incidence of relapse, as well as a worse overall survival. So this is why we exclude DTA mutations when you want to look at MRD. So the concept of DTA has now expanded. This is data from last year, which is published from Scott Bratman and John Dick's group in Toronto. What they said was it's not just DNMT3A, TET2, ASXL1 mutations. Exclusion of splicing factor mutations are also important. So what we initially called as DTA mutations, now they say is DTASI. That means DNMT3A, TET2, ASXL1, SRSF2, as well as IDH2 mutations. They say if you exclude those mutations and then do your then do your MRD analysis, you can see that NGS MRD is highly predictive of outcome. So this is something to keep in mind, that it's as we understand more and more about clonal hematopoiesis, our concepts of these what to exclude and which genes to focus on will also change. So can you just sequence everything at high depth? Uh, the issue is like this, that if you take patients and you want to sequence just post induction marrows at high depth, can you detect mutations at 0.01 WAF and so on? And the answer to that is no, because all sequencers are prone to sequencing errors, and short read sequences, especially Illumina sequences, are prone to these point mutation errors, C to T, T to G. These are random sequencing errors, and they don't typically pose a problem at high WAF of 3% or 5% or so on, because they get excluded, but based on statistics. But if you go at lower levels, there is an equal probability that this is MRD, as well as it could be sequencing error. So if you this is an extreme example of what do you mean by error correction and why this is required. So we are trying to develop MRD detection on Oxford Nanopore Technologies. Now, if you sequence ONT, or if you see sequences from ONT platform, you can see that this is a sequencer which plot. That means an alignment of sequencing reads from the ONT machine, which have been aligned to the reference genome. And you can see that there is a true NPM1 mutation here, which is present in this black box, which is a 4 base pair insertion. But there are several other errors which are present in the background. Those dashes and blue squares that you see are not really supposed to occur. So to get rid of them, we use something called error correction. So when you perform error correction, what you do, I'll be speaking about it, but I just want to tell you what happens when you do error correction. You can see the background that was so frightful in the previous slide goes away, and only the true NPM1 mutation persists. So this is on Oxford Nanopore Technologies. The advantage is that you can get MRD results literally within a few hours of sample receipt. Plus, it is incredibly cheap to do, and it is still we are exploring and standardizing this technology. We hope to have some data out in the next year. So one of the ways in which error correction can be done, or earlier ways in which errors were reduced, was to do something called as position specific error modeling. That means you calculated based on a normal reference or a normal batch of samples for every base what were the possibilities of errors that occurred. And if those errors were if that particular base error was at a or particular mutation change was at a frequency beyond what was seen in the error, or number of reads were far more, only then you could call it positive. So this is what the NEJM paper did. It was kind of crude, and it is this is not done in today's time and age. So what is done today's time and age is error corrected sequencing by introducing these UMI. So UMIs are nothing but random they are randomers or random bases into every molecule of DNA. So we use single molecule molecular inversion probes, as what you can see here, but you can also do techniques such as primer extension, PCR amplification, like I demonstrated in the ONT example, and you can introduce those UMIs. A more advanced method, what we see here is duplex sequencing, where instead of one UMI, you introduce two UMIs which are complementary on both strands of DNA. The advantage of doing this is that even when you use UMIs, there is a background error that persists, which is there at a low level, but it is there nonetheless. But when you use duplex sequencing, there is absolutely no background error. But the disadvantage is that it is very expensive and requires far more sequencing depth. So let us look at a first example. So this is a paper that we published in 2018 for NPM1 mutated AML. And you know that MRD for NPM1 mutation or MRD for NPM1 mutated AML is extremely important, because it is one of the things that is highly predictive of outcome. There is a seminal paper by Adam Ivy's group. I'm sure you would have read it, which showed that if you do NPM1 MRD, it is highly predictive of outcome. So what Adam Ivy did was he used simple real-time PCR. But the problem with real-time PCR is that there are more than, I think, 60 or 70 mutations described in NPM1 mutated AML. 70% of them are these type A mutations, but there are several other mutations that occur. So each of these real-time PCR assays require a different primer, different probe that needs to be standardized, and it is very, not so great. So this is our data set of some 100 something patients, and you can see that there are several different types of NPM1 mutations, including a novel mutation. So we developed a simple PCR based NGS assay, and it provided sequencing coverage at extreme depth. So you can get sensitivity up to 0.0001 very easily, and this is comparable to real-time PCR. The advantage of this is that you don't need to have different real-time PCR assays. One assay takes care of everything. But you cannot sequence, you cannot really do this for all mutations that occur in AML. You still require to sequence single base pair mutations like IDH1, IDH2, KIT mutations, and so on, which you cannot sequence at high depth. So we developed, so for that you require UMI based sequencing. So UMI based monitoring for blood cancers has been demonstrated in post-transplant monitoring of MDS, transplant monitoring of AML, and pre-transplant, several other papers were there. What they do is basically right at the time of DNA preparation, either by primers or by using these molecular inversion probes or by capture tech methods. When you prepare the libraries, you introduce those UMIs, and those UMIs basically help in getting rid of those sequencing reads. So we wanted to ask a clinical question: what happens when you compare flow cytometry with NGS MRD, and does NGS MRD help in getting help in predicting outcome in those patients? So we developed a 34 gene panel based on these molecular inversion probes. What these molecular inversion probes do is that right at the time of library capture, each MIP goes and binds to target DNA, introduces this introduces this UMI, and undergoes rolling circle amplification. So after PCR, every read that originates from one UMI is like this. So this in red is a true mutation, and yellow and green are all false mutations. Post hoc, all reads that originate from one UMI get collapsed, and all reads that map to our same region of the genome get clubbed together to form a consensus read family. And you can get rid of these sequencing errors in this manner. All right. So we also developed a single one-step PCR strategy for FLT3 ITD monitoring. So you can see here that we can get sensitivity easily up to 0.03% for NPM1, and for FLT3 MRD the sensitivity is incredible. You can get easily 0.005% at a routine level. So in our lab we use both FLT3 NPM1 assays as routine, and we can get sensitivity up to 0.001%. There was some criteria, like the variant should be detected at baseline. You should have an error model done for those variants. Minimum number of alternate reads must be defined, at least 3 reads for an indel and 10 variant reads for an SNV, and the highest WAF is assigned MRD. And if DTA mutations were there, they were ignored. So we looked at 201 patients of AML in morphological remission, and most of the patients were intermediate cytogenetic risks. Patients were treated with conventional 3+7 therapy. And at the post-induction time point, you can see that when you compared flow with NGS, 44% of patients were flow MRD positive, but 71% of patients were NGS MRD positive. And at the post consolidation time point, again, the number of patients who were NGS MRD was more as compared to flow MRD. So you can see here that using our approach, more than 85% of patients, we could detect one or more mutation which was suitable for tracking. The way these mutations interact also can be predicted. For example, NPM1 mutations are strongly associated with DTA mutations, IDH1, IDH2, and FLT3 mutations, but not so much with others. Uh, so where you can see here that this is a plot that shows the distribution of VAF of these mutations at MRD time points, and you can see that typically DTA mutations are at a higher level and other mutations are present at more lower levels, and we can detect mutations typically up to a 0.1% VAF. But when you do PCR based MRD, the sensitivity can be really extreme, right up to 0.002%, which was our assay detection limit. And you can see here that NGS MRD was highly predictive of inferior outcome. You can see patients both for overall survival and relapse-free survival, patients who were NGS MRD negative had a better outcome as compared to patients who were NGS MRD positive. So when we looked at paired samples or kinetics of AML MRD, you can see that what happens when you do multiple time points of pairing. So patients who are persistently MRD negative, based on NGS, they seem to have a better outcome as compared to patients who were positive at both time points. However, patients that were positive during consolidation and became negative subsequently, they too have a worse outcome. So that very early time point within first 2 weeks is what you are actually looking for when you want to look for MRD clearances. So here it shows that, patients who were MRD negative initially do very well as compared to patients who became negative subsequently. And there also is some change in mutations that we see. So some mutations are gained, some mutations are lost, and this could be because of changing assay sensitivity. So when you combined NPM1, when we combined flow and NGS results together, what we found was the greatest prediction of outcome. So patients who are negative by both modalities do exceptionally well, and patients who are positive by both modalities do exceptionally badly. And patients who are positive by any method, that means flow positive, NGS negative, or NGS positive, flow negative, those patients actually have a intermediate outcome. This has actually led to change in recommendations. So if you see the ELN recommendations, they now clearly state, based on our paper as well as the NEJM paper, that any MRD by any modality, either flow or NGS, is bad. So uh, when we wanted to look at what is the biology of patients who are persistently MRD positive, we found that RUNX1 mutations are highly predictive of MRD positivity. Not surprising, we know now that it is part of AML MR, and those patients do really badly. All right, so this is even on multivariate analysis, NGS MRD was predictive of poorer outcome. So there are some caveats as to why what patients do not get covered. So typically what we find is that if your mutation is not covered in the assay, they are typically core binding factor leukemias. We still get patients of core binding factor leukemias where you cannot get any mutation. Patients with monosomal karyotypes such as monosomy 7 or not so much monosomy 5, but monosomy 7 sometimes just don't have a mutation that you can track, and this is something to be aware of. You can also do MRD detection by tracking RNA fusions. So this was shown by Chris Hurigan's group some time ago, that you can detect these fusions as well. We too developed our own assay, Narasimha, and we demonstrated that using the myeloid panel, you can detect these fusions at a lower time point. So we could detect mutations up to 0.1%, fusions up to 0.1%, irrespective of the knowledge of the partner. So this is tracking of MLL fusion has been done in this manner. So newer advances are in the field are, can you improve error modeling to for lower VAF? So there are some newer things like context dependent error modeling, which can filter out variants to get better better sequencing results. Lastly, so has sequencing sequencing still has a potential to become main modality of MRD assessment. We will see in the few years that ALL MRD will completely move on to NGS, especially because of CAR T and other therapies where flow is not so great at doing this. For AML, you will see that for FLT3 and NPM1, already this is the standard of care. For FLT3 MRD, several papers were there at this year's ASH, which showed that this is the way to go forward. For now, the ELN recommendations are combination of flow and NGS MRD. So lastly, I want to talk to you about a cutting edge technology, which is called as single cell genomics. This is a technology by Mission Bio. What you do is you take leukemic cells, or you take post-induction, post-consolidation MRD samples, you tag them with antibodies. So you take your for sample that's come for MRD detection, you watch the sample, and you remove all the unwanted cells, and then you tag it with antibodies just like you would do flow cytometry. So we have a 40 antibody panel that you add on to it. The difference is that every antibody here, instead of a fluorophore, is tagged with a capture sequence and an PCR handle and an antibody tag. So these cells that are bound to antibodies then undergo emulsion PCR, where they are introduced and bound to beads, and you have a DNA library and a protein library that is bound to individual cell. Now then again they get encapsulated in a bigger capsule, again through microfluidics, and they bind to again barcoding beads. Now these barcoding beads go on and bind to each one of those there is also PCR primers here. So these PCR primers amplify individual cells. They perform panel-based sequencing on individual cells, and they introduce this handle through which those cell barcodes get attached. So what you have in a final library is information of the antibody that was bound to the cell, or antibodies that were bound to the cell, as well as the genomic mutation. So this is an example: a 29-year-old male with AML. He had an NPM1 mutation, KIT mutation, as well as a DNMT3A and a RAS mutation, treated with induction therapy, was negative by flow cytometry. This is how the patient's flow was at a baseline. You can see that 117 was variable, 34 was negative, DR was weak, 13 was bright, 33 was variable, and so on. And when you see these, when you see the analysis that is done from single cell genomics, this is my PhD student Anuradha, who's a really brilliant girl who did this and made these two slides. And you can see here that almost 95% of the cells are negative, but 26 cells out of those for 600 cells that got sequenced showed the presence of DNMT3A and NPM1 mutation. Now the important thing here is you not only can tell what mutations are there in individual cells, but you can also tell what was the flow or what was the antibody that was bound to them. So there are several antibodies which are present in this panel, and there are three predominant clusters that you see here. And when you see these DNA orientation of these mutations, you can see that most of the mutations here are wild type, as in dark blue. But you see what's happening in the corners. This particular cluster here in the left, you can see those dark blue dots in the left cluster, as opposed to the orange is where most of these mutations seem to lie. And those are your mutated cells. So you can then go back and see what is the antibody that was bound to those cells, what mutations there were. And this is where the future of MRD will go, that you will be able to get flow readouts as well as mutational readouts from single cells. This is still far away. It is still science that is 5 or 6 years before it becomes routine, but this is where the future will be, that you can see gene panels as well as antibodies at an individual level. You can pick up individual cells, you can tell the phenotype. It's very expensive as of now, almost 1.2 lakhs per patient, but we are generating evidence for it through cohort based sequencing for these patients. So hopefully we hope to have a paper in the coming next year. So with that, I'd like to say thank you. There are lots of huge team in the molecular lab, fellows, residents, PhD students, research staff, who are all smiling and do all the work so that I can give all these fancy talks. So with that, thank you, and I'll be happy to answer questions.
Thank you, sir, so much for the talk. Dr. Asta, would you want to start by asking? Dr. Asta, you there? Okay, since she's not there, so I will ask you. So we get a lot of patients who are, flow negative, and then we get so in the MRD, we get maybe just a hypothetical situation if we get NPM1 mutated AML with co-mutation of IDH1. And if the NPM1 is negative, we do it by quantitative PCR, real-time PCR that NPM1 is negative, but IDH1 shows a 0.4% mutation. So would you call it positive? Or would you
So,
call
so once again, we had seen several of these cases, especially the problem you have described is with NPM1 mutated AML, where NPM1 mutation goes away and IDH mutation persists. This is more pronounced in patients who have been treated with Ven-Aza kind of therapy. And these persistence of IDH mutations, there is evidence now to simply just ignore them. Typically, they are IDH2 mutations, which may not necessarily predict outcomes. They we feel that these may be part of the DTASI, the DTA that's been expanded to include DTASI and are possibly a part of clonal hematopoiesis. So there is data from that paper which I shared, Trevor Pugh's paper from Hematologica, as well as Chris Urigan's data from the pre-measure study, or where he's looked at individually IDH1 mutations, IDH2 mutations in a large cohort of patients post-transplant.
My other question is that sometimes what happens is that the patient has a core binding factor leukemia. We do again quantitative PCR for either A21 or inversion 16, whatever it is. And the patient also has a co-mutation in maybe a RAS pathway mutation in NRAS or a KRAS. We usually tend to ignore the ASXL2. But if the patient has an NRAS KRAS, how important is it to do an NGS-based MRD at every MRD test?
How important it is to do an NGS-based MRD? So we in our hospital, we do both. We do real-time PCR for core binding factor leukemia, especially 821, as well as NRAS and so on. But there is limited evidence to show that this should be done. If you have core binding factor leukemia, simply do a real-time PCR or ddPCR, you're good to go.
But so what we've seen is that our core bindings after transplant, they are relapsing after 180 days, after 200 days. And it is the NRAS clone which has expanded. So, so what we are, the hypothesis here is that what if we would have tracked the NRAS and then
You
uh,
can do it. You can most certainly do it. Whether this is an anecdotal example or not, I don't know. This is something that I have only heard of. You need to generate evidence if this is really a phenomena that we are seeing. Sometimes in AML, what we see is that the relapse is so fast that there is not much window of opportunity to do anything.
yeah, especially in RAS, I think there is a lot of extramedullary relapse because of which we can't really do much. And the other thing I was going to ask is that in how how difficult. So normally, what happens is whenever we get a bone marrow aspirate sample, the first pull always goes to flow, and then the ELN says that you reposition the needle and you take another sample for molecular. But sometimes we don't get that, and then amenable to do another bone marrow, peripheral blood versus bone marrow.
So your question was peripheral blood versus bone marrow, right? So for depends on what you are tracking. So this is really a sensitivity game. If you are tracking NPM1 and FLT3 mutations using the approach that I described, you can go extremely low depth. You can go at levels which is matches real-time PCR. Peripheral blood samples are just fine. Uh, However, there is a loss of sensitivity when you compare peripheral blood and bone marrow. This loss is typically zero 0.4 log difference. That means if the VAF in bone marrow is 40, you are going to get this at around 20. So that is something you need to be aware of. when you want to look at peripheral blood versus bone marrow. Other for other assays, especially panel based NGS, I don't recommend it. I would recommend going straight doing a bone marrow.
Okay. And the other problem which we face is again because it is not covered and if the patient does not have any mutation, especially monosomy 7 when they don't have co-mutations. Or in fact, we had some patients whose karyotype was also normal, and because 10% AML may not have any mutations, the TP53 Runx1 clone was very, very small to begin with. The VAF was hardly 5 to 6% of TP53 as well as Runx1. So now what do we do? Because it was very small to begin with. And then the patient, when he came back, when the flow MRD was kind of negative, but the T cell and myeloid chimerism. So the T cell chimerism was okay, 99%, but the myeloid showed a fall from 99 to 93. So then we started getting confused that what is happening to the patient, what to do. So, what do you recommend in such a situation? Is he the candidate for single cell MRD?
So as of now, nobody is a candidate for single cell MRD because there is just no evidence to show. It is a fancy research technique. Let's wait for a few years for this evidence to be generated.
Okay. Okay. Dr. Asta, do you have any questions?
Yeah. Thank you so much, Nikhil sir, for such a wonderful talk, which even a non-molecular person I can understand. And it was really nice. So my question is very simple, sir. So in your experience, as of now, we know that flow MRD and NGS MRD both have to be done complementary to each other. So in your experience, how many cases have you encountered where NGS MRD was negative and the flow MRD was positive? And then how do we go about such cases in the follow-ups, or how do we approach them?
So I can share that data with you. How many NGS MRD, like what is the percentage of discrepant results you are asking, right?
Yes, sir.
So there, if I can share my screen back again, I can share the exact data with you. We have published this in, in leukemia. So this is what, how many patients you get when you have discrepant results. So you can see here flow MRD positive, NGS MRD positive were 70 patients, and flow MRD positive, NGS MRD negative were 17 patients. So you have more patients who are flow negative NGS positive and less patients who are flow positive NGS MRD negative. So both ways discrepancy occurs. There is no telling, there is no saying that you get only discrepancy in this manner and not in that manner. Discrepancy occurs both by flow side and NGS side. As NGS MRD improves, as we understand more and more about things, we will see how these situation evolves. But this is the data so far, and you can see both ways. If it is missed, it is bad for the patient.
Okay. So these patients at the time of diagnosis had some mutations, or matlab, were they worked up for the mutations
Yes.
by NGS at the time of diagnosis?
Yes. Yes.
Okay. So they had the mutation.
You perform broad panel based NGS.
Correct.
So through that we know what mutations they had.
So I
Okay.
think you meant that whether these people were negative to begin with, and that is why the discrepancy is there or not. So I don't think that is the case, right? That is what you're asking, right?
No, no. Yes, but sir said that they had mutation to begin
Okay.
with also.
All
Huh.
patients had mutations to begin.
Yes.
If they
Yes.
didn't have mutations, they were excluded from the study. So this panel could account, like small panels typically account for around what our data was 83% of mutations. It will be slightly higher in other hospitals especially if you treat older patients, because we didn't have much of TP53 and all that.
Okay. Thank you, sir. And it was really nice to know about DTA-SI also, because that is the point where when happens post-transplant MRD analysis, NGS is showing persistence of DNMT3 or something and flow is negative. So that has clarified a lot of doubt in my mind. So thank you once again, sir.
Thank you. Thank you.
Dr. Pratyush, do you have any more questions? Do you have a question? So Dr. Pratyush is a consultant hematopathologist who's just joined us very, very recently.
Hi,
And
Dr.
he's from TMC Calcutta.
Hi there.
So that's what. Okay, so I guess there are no more questions. If there are more questions, I will mail you because I cannot see the questions from the delegates right now. But thank you so much. We had close to 200 people who logged in, and there were people who were live on YouTube as well.
My God.
And thank you, everyone. Thank you, everyone, for tuning in. So, obviously, there has to be a fan following, but thank you so much for accepting this offer
Thank
at such
thank
a short notice. So,
thank you very
thank you
much
so
for the
much. Thank you.
invitation. Thank you, Dr. Srinidhi and Asta and everyone. Bye-bye.
Thank you, sir. Bye. Have a great evening.
Bye.
You as well. You as well. Bye-bye.